Bismillahirrahmanirrahim. Doctors, let's start our today's last class on endocrinology. And the topics for today class is diabetes mellitus. The resources to follow for diabetes mellitus. We will go for John Murtagh. This is John Murtagh, chapter 11, along with Australian guideline for diagnosis and management. Latest guideline for diagnosis and management. And this topic is important, extremely important from AMC exam point of view. For diagnosis and treatment management plan, we will go with Australian guidelines. So, in Australian exam, for AMC exam, we will just mainly focus on the clinical feature of any disease and management plan, investigation plan, and then few topics have surveillance as well as few topics like cancerous. We will focus on screening part. For screening parts of every cancer, we'll go with Red Book 10th edition by RSAGP. So these are because AMC exam is clinical exam, not basic exam. So according to the exam point of view, we will discuss every topics from exam focus point of view. Not goes in detail, but the important things for you to pass AMC, we will just focus on this. So diabetes mellitus. No, a little bit we will discuss about diabetes mellitus from John Murtagh. Then for investigation management plan, we will go with latest guideline. I will show you. Know what is difference between type 1 diabetes and type 2 diabetes. Diabetes mellitus is a condition where there is a excessive uh, blood sugar level in the body. So how you differentiate between type 1 and type 2? Type 1 diabetes mellitus mostly occur in the adolescent, 10 to 13 year, and age of onset less than, usually less than 20, and onset is rapid. Presentation mainly polyuria, polydipsia, weight loss, and the most complication of type 1 is ketoacidosis. Ketones in the breath orders as well present and in blood as well. So, and their familial association is weak as compared to type 2. And in type 1 diabetes mellitus, there is insulin deficiency. Why? Because in type 1 diabetes mellitus, there is auto antibody against beta cell of pancreas. Beta cell of pancreas. Because due to the destruction of beta cell of pancreas, the pancreas is unable to produce insulin. So this is just a basic pathophysio of type 1 diabetes mellitus, and the association of type 1 diabetes along with HLA, HLA-DR4. There is association with, and in type 1 diabetes mellitus, there is severe glucose intolerance. Severe glucose intolerance in type 1 diabetes. Then the presentation like polyuria, polydipsia, and weight loss. This is the most common presentation in type 1 diabetes as well. Okay, move to type 2 diabetes mellitus. Type 2 mostly in the older ages after year of 40. Middle ages mostly people affected in serious slow onset, and the presentation is milder as compared to type 1, like polyuria, polydipsia, weight loss, even there is milder, and in some patient presented with this presentation. But polydysplasia, polyuria, weight loss mostly in type 1 presentation. And even the patient of type 2 diabetes is asymptomatic, and weight at onset is high. In obese population, there is more. And also the familial association is strong in type 2 as compared to type 1. The association is strong. And in type 2, there is a resistance develop where the insulin act. For example, receptor resistant. But in type 1, type 2, the insulin production is normal. Insulin produce, but where it act on receptor, the receptor resistance. So insulin present in a condition of type 2, but where it is act the receptor problem. So, and in early stages, the insulin present in the body in type 2 case, but later on with the passage of time, due to the exertion in the as well as in the beta cell of pancreas, later stages, the insulin production is also decreased in type 2. But in early stages, the level is normal in the body. And type 2 diabetes will goes in hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state. And type 1 diabetes mellitus goes in diabetic ketoacidosis in type 1. Why ketone form in the type 1? Because there is no insulin in the body. When no insulin, then glucagon increase, and glucagon will break the lipid breakdown, and due to the breakdown of the lipid, fatty acid form, and fatty acid at the end ultimately result ketone body formation. And due to the presence of ketone, the decreased pH, it means acidic situation in the body. But in type 2, there is a osmolar hyperglycemic state, and in this is insulin present. So that's why insulin present. So that's why ketone absent. So no ketone in type 2. As well as there is in type 2, there is a profound hyperglycemia. Hyperglycemia. Excessive osmotic diuresis. Osmotic diuresis. And blood glucose level might be raised to 600 to 1000, like in this range, the blood sugar level. But in type 1, there is a no the type of situation, and the blood glucose level will be greater than 350 to 400 or 500, like this, and no excessive osmotic diuresis. And type 2, due to the excessive osmotic diuresis, the patient ultimately goes into dehydration due to the excessive dehydration. So, and one of the most important things about uh, the complication of type 1, acute complication, this is acute. Chronic complication of diabetes, we will talk later, but acute complication, this is recalls as well. So, important, so that's why um, I discussed here earlier. So, in a acute complication of type 1, the patient have life-threatening mucormycosis and cerebral edema, as well as cardiac arrhythmias, cardiac arrhythmias, and ultimately heart failure and infection of life-threatening mucormycosis. Mucormycosis. And in case of type 2 acute complication, type 2 acute complication, the patient present with uh, in complication can progress to coma and death if untreated within uh, in acute stages. You can say within hours it can goes into death if untreated. And treat we have to give in type 2 IV fluid, in IV insulin, and uh, electrolytes replacement according to repulsion. And this is overall a broad view which I give you, but treatment, how to diagnose, no, I am going to discuss in detail. This is just a patient in ER and how you manage this. So for this, we have to manage immediately symptomatic treatment, and same this is acute presentation. We have to treat like this in type 1 as well, along with IV fluid, insulin, and goes with potassium or electrolytes replacement. Okay, now the things which is important. This is causes you can read it to your own time, but the important one I am डिस्कसिंग नो हम अब गाइडलाइन से कुछ देख लेते हैं जो इसकी इम्पोर्टेंट पार्ट्स हैं जस्ट 1 मिनट मुझे गाइडलाइन ओपन कर लेने दें तो डॉक्टर्स फॉर डायग्नोस this is the management you have to follow that the initial test for sorry the initial test for diabetes mellitus to management is fasting blood glucose level or random blood glucose. This is the initial test. And for example, the patient presenting with the feature of diabetes mellitus, as we discussed, and you have to make diagnose, and you will go for blood sugar level test, and you will go for fasting blood sugar level. If the fasting blood sugar level less than 5.5, diabetes unlikely. So retest in 3 years. This is normal group of population if indication. In second cases, you will do the fasting blood glucose and result 5.5 to 6.9, and this group of range patient possible to have diabetes possible. So you for confirmation you will go for OGTT. OGTT is confirmatory best test, gold standard test. Guys, remember this. The fasting blood glucose level is initial test. If ask next step, next step, you will go for fasting blood sugar. And if ask confirmatory and diagnostic test, you will go for OGTT. So write on this. This is the best test. Best. Sorry, it's difficult to write here with this pen, but this is best test, and this is initial. Fasting blood is initial and OGTT best. And for example, the patient fall in the 5.5 to 6.9 diabetes likely, you will go for OGTT, and in OGTT you will do the two tests, fasting blood glucose and 2-hour oral glucose tolerance test. If the result of fasting blood glucose less than 6.11 or 2-hour oral glucose test less than 7.8. So diabetes unlikely in this group of age. But if you perform fasting blood glucose and the value of fasting is greater than 6.1 to 6.9 R2R glucose tolerance test, uh, the value less than 7.8, you will go for impaired fasting glucose test, impaired fasting glucose. And again, you have to do retest in 1 year, 1 year of it. After 1 year, every year you have to retest. Okay, then uh, uh, if the value of fasting blood glucose less than 7.0 or the value between 7.8 to 11.1, you will go for impaired glucose tolerance test. And same like you have to retest in 1 year. And if the value of fasting blood oral glucose tolerance test, fasting glucose greater than 7, 2 hours oral glucose 2 hours oral glucose tolerance test greater than 11.1, you will make diagnose it is diabetes confirmed. So this way you have to approach for diagnose. And another test, you can do a fasting blood sugar or you can go for HbA1c. HbA1c will tell us the record of the previous 3 months of glucose control in our body. So HbA1c, if value less than 6, you will rule out the diabetes is unlikely. So retest in 3 years if indicated. This is normal group of population. We will do a test every 3 yearly. But if the result between 6.4 to 6 to 6.4, you will go for this is high risk population and you will go for retest in 1 year. Might be in future will develop a diabetes, so you will go for a retest in 1 year. And if the value greater than 6.5 as a result, so diabetes likely, you will confirm with repeat. We have to repeat HbA1c. So and if on repeating the HbA1c, the result will be same. So we will make diagnose it is diabetes mellitus. डॉक्टर्स ये इम्पोर्टेंट पार्ट है, डायग्नोज ये क्वेश्चन में आ रहा होता है। और ये है कि सिंपल है, कोई मुश्किल नहीं है। आपने ब्लड टेस्ट किया, फास्टिंग ब्लड शुगर की, अगर लेस देन 5.5 है तो रूल आउट कर दिया, क्योंकि जो ब्लड शुगर की वैल्यू है नॉर्मल बॉडी में होनी चाहिए वो 3.5 टू 5.5 तक होनी चाहिए। ठीक है, अगर 3.5 से कम होती है तो वो हाइपोग्लाइसेमिक स्टेट होती है, और इन बिटवीन ये गुड स्टेट वो उसकी वैल्यू। अगर वैल्यू 5.5 टू 6.9 है तो पॉसिबल डायग्नोज हो सकता है, तो हम ओजीडीटी करेंगे। ओजीडीटी बेस्ट बेस्ट टेस्ट होता है डायग्नोज के लिए, तो इसमें हम फास्टिंग कर लेंगे। तो अगर उसकी वैल्यू 6.1 आती है फास्टिंग, या 2 आवर्स ग्लूकोज जो टेस्ट करेंगे वो लेस देन 7.8 है, तो ये हमारा डायग्नोज डायबिटीज का डायग्नोज रूल आउट हो गया कि इससे नहीं हो सकती इस पर्सन को। और अगर हमने टेस्ट किया और हमें वैल्यू 6.1 टू 6.9 पे मिलती है, तो वो टाइप और जो 2 आवर्स ग्लूकोज टोलेरेंस टेस्ट किया और उसकी वैल्यू लेस देन 7.8 है, तो हम इंसुलिन सॉरी इम्पेयर्ड फास्टिंग ग्लूकोज टेस्ट की तरफ जाएंगे और रीटेस्ट करेंगे एवरी इन 1 year। ठीक है, बिकॉज दिस पेशेंट फॉल इन हाई रिस्क कैटेगरी एज कम्पेयर टू अदर पॉपुलेशन। एंड इफ वैल्यू ग्रेट अगर उसकी वैल्यू लेस देन 7 है फास्टिंग, और 2 आवर ओजीडीटी की वैल्यू 7.8 से लेके 11.1 तक है, तो हम फिर इम्पेयर्ड ग्लूकोज टोलरेंस टेस्ट करेंगे, और ये भी हमने ईयर के बाद इसको रीटेस्ट करना होता है। और अगर वैल्यू एट द स्पॉट ग्रेटर देन 7 आती है फास्टिंग में, और 2 आवर्स ग्लूकोज टोलरेंस टेस्ट में ग्रेटर देन 11 आती है, तो ये हमारा डायबिटीज कन्फर्म हो गया। और हम यहाँ तो फिर हम HbA1c कर सकते हैं दूसरे टेस्ट, अगर लेस देन 6 से तो रूल आउट कर दिया ये डायबिटीज नहीं है, और अगर 6.4 तक आ रही है तो वो रीटेस्ट एवरी 1 ईयर भी करेंगे, और अगर 6.5 से ज्यादा आई है तो हमने कंफर्म रिपीट करना है HbA1c को, अगर उस पर भी वैल्यू रेज आती है तो ये डायग्नोज हमारा कंफर्म हो। डॉक्टर, डज दी थिंग्स मेक सेंस? एनी क्वेश्चन? ओके ओके, थैंक यू डॉक्टर। मूव टू नेक्स्ट। And one more score we have, score to calculate the risk of population having a future risk of diabetes. We have OST risk score. If score is greater than 12, we will consider as high risk category to develop diabetes. So according to this, we have to manage this patient. Okay, move to next. Next part is important part before going to treatment. This is from Australian guideline. So before this, we will go for John Murtagh to read just a basic things, and then we will move for treatment. So, okay. And doctors, and this is the causes. You can read it your own time as well. Okay. The important ones we will discuss for your exam point of view. This is candidal infection in diabetic patient. There is the patient's immune system is weaker, so with the passage of time there is a lot of infections compromised, and this is a feature: polyuria, polydysplasia, loss of weight in type 1, tiredness and fatigue, and then the many infections in genital infection as well, and this is a key feature: diabetes, thrust, weight loss. This is diabetes type 1. And due to the candida albicans, vulvovaginitis, pruritus, mellitus. History you will taken, you can go through it your own time. And the things investigation we already discussed. The random blood glucose or fasting blood glucose. This is the initial test we have to run for initial. Before going to best test, we will do the initial one, and this is fasting or random blood glucose. And best steps test to follow up oral glucose tolerance test. This test we also do in pregnancy at 24 to 48 week, and this is best test to diagnose, make the diagnose. Or we can do the HbA1c if indicated. This is also uh, to make DX diagnose in pregnancy, and we will do this test 24 to 28 week in no high risk population. But in case of high risk population, we will do it before. There is a risk factor: age greater than 40, family history, overweight, sedentary lifestyle, polycystic ovarian, ischemic heart disease, medication, and the important one: original Torres Strait Iceland population, Pacific Islander population. These group of people is high risk. So in these population, we have to screen uh, this population, especially this population. We have to start screening in age of 18 years. So doctor screening is important part for original population. This screening pattern is different as compared to other Australian population. Aboriginal, Torres Strait Islander, Pacific Islander, these are in one group. And these population, we will start screening accordingly at the age of greater than 18 year. But in case of other population group, we will start screening at the age of 40 or younger, and even family history positive, type 2 diabetes, we will start accordingly. Okay, move to next. Diagnose, we already done. So the things I discussed, follow that only. And for diagnose, this is table we already discussed with latest guideline. Diabetes is less than 5.5, diabetes unlikely. If 5.5 to 6.9, fasting or random 5.5 to 11, diabetes uncertain. So we will go for oral glucose tolerance test and 2 hours glucose level. If less than 7.8, diabetes unlikely. If 7.8 to 11, so we will go for impaired glucose tolerance test and retest in 1 year. And if level greater than 18, the diabetes is confirmed. And in case where there is a fasting greater than 7 and random is greater than 11.11, 11.1, the diabetes is likely. So doctors, everything is fine. The things make sense to all of you doctors. Okay, okay. So move gestation diabetes. The all pregnant women should be screened at 24 to 48 week with 75 gram oral glucose tolerance test. So this is thing. And complication before going to treatment, complication. This is the chronic complication. Chronic. Chronic complication. And we discuss acute complication as well, but this is chronic complication. So retinopathy, diabetic nephropathy, neuropathy, macrovascular complication. So in retinopathy, there is proliferation of blood vessel, a new blood vessel form, and this is proliferation of new blood vessel and lead to at the end cataract blindness and many other complications. And diabetic nephropathy, there is a microalbuminuria along with macroproteinuria, and ultimately the patient goes in CKD, diabetic nephropathy. And for best treatment of this type of patient is AC inhibitor or herbs. Drug of choice in these patients, we will go for AC inhibitor. Then third is the neuropathy. The neuropathy, there is a lot of complication affected the small fibers as well as small fiber neuropathy lead to the pain and paresthesia, and large cell neuropathy in which there is the absence of sensation in this, and this also damage the our third cranial nerves during which there is eye down and outward, the diabetic most complication as well. Due to this there is a ptosis and diplopia, and in this the patient preserved the pupil response. When we put the light, the response of pupil is preserved in these types of patient. And for this treatment, we will go for amitriptyline, gabapentin, NSAID to treat the pain as well. These are the neuropathy complication I am telling you, and also neuropathy complication lead to the gloves and stocking distribution. I mean, there is no sensation in palm of hand and soles of foot. There is a loss of pain, temperature sensation over there. And also in neuropathy, the patient also goes in gastroparesis or neurogenic bladder. The patient don't know the bladder is full and develop overflow incontinence. These are the complication, just I am telling you. And then the important one is macro. Macro complication, the most common cause of death. This is as well a question. Most common cause of death in diabetic patient is coronary artery disease. MI is most common. Then in macrovascular complication, the stroke as well, most common, and peripheral artery disease. These are macrovascular complication. And also we can say this is silent MI. The things we already discussed, MI complication, you can read it soon on time. Microvascular complication, retina, artery, kidney damage, nephropathy. You can read, give read simple. And there is a retinopathy and megalopathy, neuropathy, I am discussing all the things detailing with you. Just need superficial read. It's your own time. Infection, a lot of infection after those patients who have poor controlled diabetes and mucocutaneous infection, UPI, cystitis, pneumonia. These are the pyelonephritis. These are the infection. And then a metabolic complication, diabetic ketoacidosis, hyperosmolar hyperglycemic in type 2, and diabetic ketoacidosis in type 1. Other complication, there is a cataract, sleep apnea, refractory erga of eye, depression. So this is, and for prevention or treatment, first line is always lifestyle modification in prevention. We advise to patient to do more exercise uh, as he or she tolerated, along with modification of diet. Then we are going toward the management of diabetes. In diabetes mellitus, type 1 diabetes, always, first of all, before going to medication, lifestyle modification. LSM, lifestyle modification. If lifestyle modification is ineffective, then we will add insulin in type 1, because in type 1 there is deficiency of insulin due to the autoantibody against beta cell of pancreas. And in type 2 diabetes mellitus, there is because the insulin production is not problem. The problem where their problem, their resistance increase, or might be due to the obesity or any other causes, their resistance increase. So to overcome the resistance, we will add drug to act on the tissue receptor, which increase the sensitivity to insulin. So we will add, first line is metformin. This is MCQ. Before going to metformin, the same like as a type 1, we will go for lifestyle modification. And if lifestyle modification is ineffective, then we will start with monotherapy with metformin. And if monotherapy is ineffective, then we will add second drug. And second drug, I will discuss the guideline with you, how you will add accordingly. Treat and prevent patient complication of ketoacidosis type 1, type 2, there is a type 2 hyperosmolar coma, complication of type 2. There is the graph to show there where is the diagnosis of diabetes and baseline level. So, okay, move to next, doctor, next. Doctor, so far any question? Or is it okay to all of you? Type 1 diabetes, these things are same. And we will add type 1 after lifestyle modification. Okay, okay, doctor. And type 1 diabetes, we will add insulin. And insulin name you can, uh, for every name you don't need to memorize all this, but at least you must know rapid and short, intermediate, long acting. The long acting is important one. Glargine, determine, Datimir, and then short acting there is a regular, and rapid acting there is a insulin lispro. So at least these three you must know. So these things you don't need to memorize. So move to next, type 2. Type 2 always, as I discussed, always for 1 and 2, the first line is lifestyle modification. Lifestyle modification, diet, exercise program, weight loss program. If this is ineffective, then you will add metformin. And metformin, according to the patient comorbs, you have to add, you have to choose the drugs. For example, metformin, there is lead to lactic acidosis. So avoid these drugs in renal failure patient, because it will worsen more effect on kidney. So according to, you have to go. And also a metformin side effect, weight loss. So it is good to weight loss, because in type 2 there is most effect in obese population. So it is good for obese. And if there is a patient have contraindication or have renal failure, so avoid this metformin. Then according to this, you have to add, for example, sulfonized ureas, and there is this types of class will, as a side effect, will gain weight gain and hypoglycemia. So according to cohorts, you will add then glitazones. Glitazones will lead to heart fail and edema. So if patient is already had heart fail, so avoid glitazone in these patients. If patient have already heart fail or edematous condition, so avoid glitazone in these patient group, because this will cause increased risk of MI and cerebrovascular death. Cerebro, also cerebrovascular death, as well as heart fail and lead to edema as well. Okay, move to next. GLP-1. In case of the patient RSD have pancreatitis, so avoid GLP-1 in this type of patient, because their side effect is also pancreatitis and weight loss. GLP-1 drugs like exenatide, liraglutide. This is the drug class name, exenatide and liraglutide. So avoid these in patient with pancreatitis. DPP4, DPP4. These drugs will cause UTI as well as upper respiratory infection like respiratory infection and urinary infection. So if patient is already have present with UTI or any respiratory infection, so avoid DPP4 in this patient group. Then SCLT2, the SCLT2 inhibitor uh, can cause glycosuria and UTI, vulvovaginal candidiasis infection, and also lead to renal insufficiency. So if patient is already have renal problem, so avoid SCLT2, sodium glucose co-transport inhibitor, like canagliflozin, dapagliflozin, empagliflozin. So these types of drugs in SCLT2. So in case of renal insufficiency, our patient have glycosuria, UTI, vulvovaginal candidiasis, so avoid these drugs in this group of patient. And DPP4 is also UTI and upper respiratory infection. So according to this, according to cohorts, you have to choose drug accordingly. First line is always monotherapy. Start with metformin. With the passage of time, if monotherapy is ineffective, then you will add second drugs. Then you will add second drug as well. According to cohorts, you have to add the drug. So, and if dual therapy is ineffective, then you will go for third drug. This is the Australian guideline. First line is always metformin. More down the logarithm and check the review. So the first line, focus on this. First line is always metformin. You will add metformin. And in some stages where there is a deficiency of insulin, because in later stages of type 2, the sometimes insulin deficiency, so we can add, but always first line, you have to memorize this insulin. This is the first drug you have to add. As usual, first line therapy, unless contraindicated or not tolerated, then we will go for sulfonized urea if there is contraindication or insulin. And second line drug, for example, first line we add, but this is ineffective. So we have to add a second line drug. Add on oral agents or injectable therapy. We will go for anyone, SGLT2 inhibitor or DPP4 or sulfonylurea or GLP-1. According to comorbs, we will add these anyone drug, anyone for as a dual therapy. And third line drugs, if two drugs is ineffective, then we will go for a triple therapy, including metformin or SGLT2 or DPP4, for example, and two of the drugs add third drug combination, third class. For example, we added metformin SGLT2. No, we will add DPP4 if there is patient have no comorbid or sulfonized ureas or GLP-4 or insulin. So like this way you have to choose the drug. And this is the way the AMC asks question. And AMC never give you a very straightforward question. In presentation, you will see a lot of contraindication. So according to this, you have to treat. So see here as well, these things we discussed. डॉक्टर्स एनी क्वेश्चन, किसी को कोई सवाल है तो पूछ सकते हैं. ड्रग्स की जस्ट आपने कंट्राइंडिकेशन आपको पता होनी चाहिए किसके लिए क्या चीज़ें हमने करनी है क्या नहीं. ये सारे ड्रग्स हैं, इनकी कंट्राइंडिकेशन भी इधर लिखी है. आप वो मैंने वो मेंशन भी कर दिया अपने वो नोट्स के अंदर, तो आप वो वहां से पढ़ लीजिए. कंट्राइंडिकेशन पे फोकस करना है आपने. यू हैव टू फोकस कंट्राइंडिकेशन, ड्रग क्लास, प्रिकॉशंस. So this is the important one. For example, metformin, the renal impairment. In renal impairment, GFR less than 30, don't go for metformin. Sulfonylurea, severe renal or hepatic impairment. So like this, as I already discussed with you, all the things with all of you people. So just memorize it your own time. अगर किसी को कुछ सवाल है तो वो पूछ सकते हैं, नहीं तो हम आगे मूव करते हैं. ये ड्रग सारी ये ऑस्ट्रेलियन गाइडलाइन है, डायबिटीज ऑस्ट्रेलिया, ये वहाँ से हमने वो दी गई है. तो ओके, तो डॉक्टर्स ये डायबिटिक कीटोसिडोसिस एंड hyperosmolar glycemic state. This is type 2 diabetes and diabetic ketoacidosis type 1. Present with type 1 diabetes and patient is greater than 20. Infection, trauma, alcohol, these are precipitant factors. Symptom, abdominal pain, nausea, vomiting, cosmal respiration, mental status change. And the important one is fruity acetone breath smell, because acetone are present. So the fruity acetone smell ordered in breath as well. And lab value glucose will be greater than 250, or metabolic acidosis bicarbonate less than 18, increase urine and serum ketones, increase iron gap. So this is type 1. You can differentiate. And type 2 is hyperglycemic hyperosmolar syndrome. Patient with type 2 diabetes, same as diabetic acidosis, but including dietary indiscretion, profound hyperglycemia, mental status change, and prominent in HHS in diabetic. And glucose level, you will see the extreme greater than 600 to till 1000, no acidosis and no ketone. These are the and this normal serum gap, because there is a no acidosis condition, and serum osmolarity greater than 300. So doctor, this is just uh, information for you to differentiate them. And doctor, this is the things I already delivered. So according to this, the green one is preferred and avoid red one is avoided. So according to patient concern, underweight, you will go for this medication. Overweight, you will go for this. So CKD patient, you will go for these medication. So this is circular form. You can memorize even in circular form just for to memorize. And the red one you have to avoid in this patient group. Overweight group, we will go for GLP-1 or SGLT2. So according to this, every patient cohort, we will go for it. Doctors, and next important things, diabetes screening, we discussed it already. Normal population age greater than 40 years are the toad states. Iceland population or original population greater than 18 years. We will start screening from 18 years, but other population we will start screening from 40 years. And test we will do the OS risk score and frequent every 3 years. What is OS risk score? This score is to calculate the risk of diabetes uh, diabetes mellitus develop in future. So if score greater than 12, the patient is in high group risk. And in OSD score, we will calculate the age, gender, their ethnic group, like this. So according to this, we will give the score and put the score and calculate all the total score. According to this, we have to categorize the patient. Then high risk OSD score greater than 12, women with history of gestation diabetes, women with history of polycystic ovarian syndrome, people with history of AMI or stroke. These are a high risk group. So we will go for fasting blood sugar, fasting blood sugar every 3 yearly. Every 3 yearly we will go for fasting blood sugar. And in high risk, impaired glucose tolerance test or impaired fasting blood glucose will go, and every 12 months we will do fasting blood glucose. But in high risk, this score is greater than 12 fasting blood glucose, and in these population group, we will start uh, do the test every 3 years. But in original population, these screening start from the age of 18 years. Doctors, is it okay? सबको समझ आ रही है? स्क्रीनिंग से आपको क्वेश्चन आ सकता है, मैनेजमेंट से क्वेश्चन आएगा आपको, डायग्नोज में क्वेश्चन आएगा, मोस्टली ये इन्हीं में से वो एमसी को पूछ रही होती है। एंड और स्कोर आपने वो करना होता है, और 3 ईयरली फ्रीक्वेंसी आपने वो टेस्ट करना होता है। और अगर एक आम पॉपुलेशन है, अगर हाई रिस्क है तो उसमें फास्टिंग करेंगे एवरी 3 ईयरली। अगर वेरी हाई रिस्क है, इम्पेयर्ड ग्लूकोज टोलरेंस टेस्ट या इम्पेयर्ड फास्टिंग ब्लड आया उसका, इट मीन्स कि ये हो सकता है कि इसको डायबिटीज हो जाए, तो आपने या नियर टू डायबिटीज, तो आपने 12 मंथ टेस्ट को रिपीट कर लेना आपको। तो डॉक्टर्स मूव टू डॉक्टर्स, एनी क्वेश्चन? और शुड वी मूव टू नेक्स्ट? ओके, just one minute. So doctors, these are the important things which I tell you. No need to go the extra thing. The GM written a lot of things you don't need. So just quickly, we will see what's the GM written, and then we will end our session. Metformin considered as first line agents for all patients with type 2 diabetes. We discuss this. So first of all, lifestyle modification. We will go for lifestyle modification. If this is ineffective, then add monotherapy metformin first line. along with metformin. This, if this is ineffective, then we will combination of oral therapy, metformin along with sulfonylureas or SCLT2 or DB4. According to this, we will choose combo. We will choose any of one. Then we will go for add one of the SCLT2 inhibitor, DB4 inhibitor, acrobos or getazone. Any drug, third drug we will add. Like this, we have to add and see the response of the treatment. And metformin withdrawn, other agents taken care. Add insulin. At the end, we will add insulin or GLP agonist. So like this, first monotherapy, if ineffective, then dual therapy. If so far ineffective, then third line. And if ineffective, then we will add insulin. So like this way, you have to approach to treat the diabetes patient in Australia. And for ACE inhibitor is excellent medication. Those patients who have MI along with hypertension. So we will treat ACE inhibitor with ACE inhibitor. So another things, rest of things in this chapter, I already discussed the important ones with you. So diabetic ketoacidosis, we already discussed. Management already discussed. We have to treat symptomatic IV insulin, ECG to rule out the arrhythmias. Hyperosmolar, this is type 2. So I think no need to discussion over here for type 2. We already discussed a lot of things. Lactic acidosis, type 1. In type 1, the ketone body is formed. So gastroparesis, this is a complication, chronic complication of type uh, uh, diabetes mellitus. So this is the important things you have to go through in this chapter. No need to go any other chapter. Doctors, any question? Any question? Okay, doctors. Thank you. Thanks for your attention. Okay, doctor.